as you're listening to Dr. Ward today, to keep something in mind that we keep in mind when we do presentations, that you're really wearing two hats. You know, you need to make your own decisions for your own healthcare for the future, but chances are also pretty good that you're going to be somebody else's substitute decision maker. So wear the hat of the, I'm going to say patient, but also wear the hat of the person who may be called upon to make very difficult decisions in a very emotional situation. So those two hats as we go forward. I ask you to mute your phones. Keep your cameras on if you like. If we have trouble with the wind, we may ask you to turn your cameras off. But this time, if you could just keep muted. And on that, I will turn this over to Dr. Ward, who's going to share her screen and then walk us through her presentation. So welcome, everybody, and welcome, Dr. Ward.
Okay, so hello, everyone. Good morning. I'm just going to get myself started here. Share. Okay. Can everyone see that?
Yes.
Good. A thumbs up. Okay. All right. So I think the format of these meetings has been to ask questions of the guest. And so this is the first question that I got presented with. Tell us about your work and why you believe advanced care planning conversations are important. So I have to apologize that most of these questions are very complicated. And so you're going to hear kind of long-winded answers. And some of it you're going to be very familiar with, but I hope some of it is new as well. So I come into this from palliative care, where I've been working extensively since the late 1980s. And if you think about this work, it's really a philosophy of care, which is aimed at the relief of suffering and improving the quality of living and dying. The palliative care accepts death as being a natural part of life, and it's delivered by a team. It's appropriate for anyone who has a life-threatening illness or life-limiting illness, and it can take place during the treatment of that illness, or it can become at certain points the total focus of care. Now, it involves the attention to and relief of suffering. So this is a fellow that a colleague in the States who is an internal medicine specialist, and he has written this book, and there's a new edition out sort of 20 years later. So he defines suffering as occurring when there's impending destruction of the person, that person perceives that, and that suffering can continue until the threat has passed. So you can imagine someone with a life-limiting or life-threatening illness, this actually will never happen. So the suffering may continue throughout the whole illness. The other point that he makes is that it is very, very difficult to know whether someone is suffering unless you ask them. Suffering is something very private, very personal, and very complex. So it involves the physical and biological, it involves the personality, it involves what they've gone through in the past, whether they have any secrets they're trying to hide until they die. It involves social poverty, all the social determinants of care. It involves the spiritual, and involves that tension between being able to do things and then on the journey of illness, perhaps not being able to do what we used to do and just being comfortable with being. So Dr. Casal also mentions that fear can be a source of suffering, and the people walking down the street who are not even ill are afraid of being ill and afraid of dying. So understanding the fear is very, very important. Now, one of the main sources of suffering in our society is the isolation, loneliness. Loneliness can be a great source of suffering. And if anyone's read Tolstoy's The Death of Ivan Ilyich, you'll see that in that culture, no one would acknowledge that he was dying. So he was totally alone with that and unable to share it with anyone. So this became a wound. Henry Nguyen has written extensively about loneliness and about if you are wounded, then you are more capable to be a healer for others. He talks about creating hospitality, creating a space where the guest, that is the ill person, can find their own soul. So the philosophy of palliative care then strives to help the patient and family. So it's not just patient focused, it's patient and family focused with these complex needs in all those domains. It strives to help them with their expectations, their hopes, and their fears. It helps patients and families prepare for and manage life closure and the dying process. It helps them to cope with loss and grief, both during the illness. So the patient is losing things. So there's a series of losses during an illness trajectory or journey. So palliative care aims to treat all active issues. It aims to anticipate and prevent new problems if possible. And it aims at providing opportunities for ongoing meaning, growth during this, and what we like to call self-actualization. So Dame Cecily Saunders is the pioneer of the modern hospice palliative care movement. She has died a few years ago, but emphasized how important it is to alleviate the suffering. Because if we don't, then the potential that remains to the person would be lost. So meticulous attention to detail can lead to effective treatment until the end of a person's life, which transforms both his experience and the memories of his family. So in other words, creating opportunity to live until you die. So the work that I've done with patients and the work that I've learned from is palliative care. So palliative care accepts that death is a natural event. We acknowledge that sudden death is quite rare. So we have an opportunity during illness. Palliative care is person and family focused as opposed to disease focused. So we're not fighting cancer. We're not fighting end-stage cardiac disease or fighting ALS. We're working with the family. Palliative care strives to understand the personal nature of suffering. And so how can you do that if you don't have these conversations? So how do we meet the challenges within our discipline? We accept the invitation to encounter by conversation. And I would recommend, in addition to the books you've already heard about, that you read Being Mortal by Atul Gawande, if you haven't already read that wonderful book. Okay, so let's take a breath. And that's kind of where I'm coming from, where I've learned. Question number 2, what is important in choosing an SDM? What qualities in the person are important? And what about that issue of a single SDM or a committee? Like, for instance, I have 4 sons between ages 37 and 45. Would I choose them as a committee? As you know, any family with more than 2 people in it is dysfunctional. So just think about that. Okay. All right. So let's talk about what the SDM will need to do. So they'll need to engage in advanced care planning. So it's a process. They'll need to communicate about wishes. You're going to need to let this person know about your future health, where you are at with this illness that you may have, and your personal care wishes. This person is going to need to speak for you when you're no longer able to speak for yourself. You're going to communicate with this person while you're capable about how you want to be cared for if you become incapable. You're going to have to trust this person and give them the authority to act on your wishes. So why are we talking about this at all? Well, we know from the research that if you express your wishes in advance and they are respected, that there's a chance that you can get the treatments that you want and not get the treatments that you don't want. We know from research that the family members will have less stress and anxiety because they are certain about your wishes. So we're speaking about the research, which has confirmed that it's more likely the patient will get the treatments and the death that they want, the life that they want, and the death that they want in the place that they would like it to be. They would rate their quality of life higher, and the family, the bereaved family, would rate the quality of death higher. We all hope that we'll be totally competent and be able to die in that manner. I imagine myself saying something profound and then just dying, like they do in the movies. But in fact, most deaths do not occur this way, and especially people with chronic illness tend to not die in that manner. They often have a period of time when they cannot express their wishes. So everybody does have a substitute decision maker. That's important to realize. And I'm sure you've seen this list. So this is something which our government has established. So everyone has a substitute decision maker. Most people don't have a guardian, or some people will have a power of attorney for personal care if they've already done that work. But most people don't have a representative appointed by the Consent and Capacity Board. So we're usually turning to a spouse or partner, a child or parent, or a relative. The thing is that the person that you want to be making the decisions for you? And in one of my stories, you'll see that this comes out. You also need to realize that all persons on the same level have equal ranking. So for instance, my 4 sons would all have the same equal ranking, but they may not, in my opinion, have the same capacity to make decisions for me for various reasons. Okay, now, these are the criteria for choosing a substitute decision maker. So the substitute decision maker must be capable. And sometimes when you choose the person, they are, for instance, a spouse, but there may be over time changes in that person that make them not the best person, or even if they develop an illness themselves, or they may die. I mean, at one point, my substitute decision maker was shared between my mother and my mother-in-law. My mother developed dementia and my mother-in-law died, but I didn't update them. So, it's very important to think about that. They must be at least 16 years of age unless they are a parent of the person that they're acting for, not prohibitive. This is really critical. They have to be available, reachable, accessible, and they have to be willing. So you can't just pick someone without asking them. So this is what the power of attorney for personal care does. It gives authority to another person to make decisions for you, but only if you become incapable. So we always in healthcare turn to the person as long as they are capable. And we'll talk about that a little bit more. Okay, and so the person is an attorney for personal care. You can make your wishes known to this person that you choose, either in writing, orally. Oral wishes are just as valid as wishes in writing. However, when you're a healthcare professional and you're listening to a patient and they tell you something, you have to document that for other people on the team. There's no specific form of writing down your wishes, and we encourage people to not just do wishes, but also values, things that are important to them, goals. Okay. And it's not legal for facilities, long-term care facilities, retirement homes, etc., to require written wishes. Just so you know that. They usually ask, but it's not legal for them to insist upon that. So you've probably heard about level of care forms. And we have to be really careful about that. We have a better understanding of these things now. A level of care form is not specific to a situation. And so we have to be very careful that that we understand this. It doesn't apply to the person's health condition at this time, in the present, in the moment, and it's not a consent. You've probably heard about allow natural death. So this has become a little bit more used rather than no CPR. And just so you understand what this means, allowing a natural death probably implies that rather than engaging in futile attempts at resuscitation, that we would aim at being present with the person and supporting the family at the time of death. So allowing a natural death to unfold. So it is not a treatment. Okay, so the healthcare team needs to get consent, or we call it refusal of consent. It sounds terrible, they refuse consent, but it's just that they didn't consent. And we must get it from the person if the person is still capable, and avoid turning to a substitute decision maker or family member if the person is capable. Sometimes it feels like you're being kind, but you know, that is not legal. If the person is not capable, then we turn to the substitute decision maker. So what are we going to do then? We're the healthcare team. We're going to speak with the substitute decision maker or the patient if the patient is competent. We have to talk to them about the nature of what we're proposing. What are the expected benefits? What are the risks? What are the side effects, possible side effects? Are there any alternative courses of action open to the patient? And what are the likely consequences if the patient does not consent? So your SDM that you're picking is going to make decisions based on what you've shared with them, what you would want if you were capable, or if they don't know that, what they will consider is what are in your best interests. And this will be a collaboration. The SDM is not alone. The SDM is collaborating with the healthcare team. And if your wishes are not known or cannot be honored, then the decisions will be based on your personal best interest, which affirms life. So the decisions would be made to prolong your life if you haven't engaged in these conversations. So during this collaboration, the role of the healthcare provider would be to inquire of the SDM, what are the goals, values, and beliefs of this person? What does the SDM, acting for the patient, what does the SDM understand about the health condition, the diagnosis, the prognosis, the current situation right now? The healthcare provider will give information, will discuss prognosis, treatment, care outcomes, provide information on what they're planning to do right now. We're going to give IV antibiotics. We would like to give IV antibiotics because they would describe the nature of the treatment, the benefits, the risks, the side effects, what are the alternative courses of action, and the consequences of not having the treatment, and then be open to answer any questions from the SDM. So we must, as healthcare professions, get informed consent. And the consent is related to that particular treatment that we're thinking. So wishes are not consent. So your SDM is going to have to discern in collaboration with the healthcare professional from your wishes. So if you have explained to them if I have a terminal illness, if I'm in intractable pain, if I develop dementia, if this happens to me, and it's very helpful if you have shared your wishes around this known condition, which you are on a journey with. If you can share your beliefs, what's important to you, and any particular goals that you would have with your substitute decision maker, this helps them in these collaborations with the healthcare team. It's important to recognize that people can say no to a treatment, even if the treatment seems to be in the best interest of the patient. So if there are extenuating circumstances, ongoing suffering, if the patient is ready to die and would welcome death, then they don't want any life prolonging measures instituted. So it is legal and right to refuse life prolonging treatment if that is the wish of the patient. It is important that the SDM understand and appreciate the consequences of the decision. Okay, so talking about capacity. Capacity has nothing to do with whether or not someone agrees with you. So just because the healthcare provider thinks that a third course of chemotherapy for this patient is what should happen because this is what we're fighting the cancer, that doesn't mean that if the patient says, no, I'm done with the chemotherapy, that there's anything wrong with their capacity. Okay, so it has nothing to do with the healthcare provider's opinion. Capacity only speaks to the understanding of that patient or substitute decision maker who's making the decision. Okay. A person is capable when they're able to understand the information that's given and the consequences of the decision that they're making. And when the person is not capable, then the substitute decision maker comes in. So advanced care planning is this process of reflection and communication about values, beliefs, and goals of care. It's a process of planning for a time when you might not be able to make your own decisions. The process involves discussions with family, friends, and healthcare professionals. So, I mean, you can't just name a substitute decision maker and then not talk to them, right? That's not going to be helpful. And it's a process in which you're going to appoint someone and share your wishes. Okay. So it is not one conversation, clearly. It's not a consent to any treatment. It's not a refusal of any treatment. And it's not a checklist, and it's not a secret. You do set your substitute decision maker up for trouble if you don't share more widely with other family members, because as I mentioned, there may be some conflict that's set up. But in some situations, that's unavoidable. So the substitute decision maker must be a person who's able to accept this responsibility. Okay, so things to remember about SDMs. They need to be available. They need to be willing to do those things that we've just talked about. They must be interested or at least willing to engage in intimate conversations over time with you because you are going to change. And they must be able to engage in conversations with healthcare professionals. So I'm going to tell you a couple of stories. So here's a story of a gentleman. It's a real story. He's 65. He was diagnosed with tongue cancer. And when I say he's meticulous, he's a tiny Italian tailor who designs suits and shirts and things from scratch. Very meticulous man. His mother died choking from thyroid cancer at an advanced stage. He receives excellent care for his tongue cancer, chemotherapy, radiation. The cancer responds, and there's no disease found at this time. He suffered severe side effects, however, from the treatment, and he required a feeding tube for greater than a year. He never recovered his ability to swallow solids. So all the past, he lost his taste from the radiation treatment. He could never taste red wine. His teeth all fell out from the radiation treatment, and the radiation treatment caused him to suffer permanent dry mouth. He continues to be haunted by the specter of the cancer, and he is certain that it will return and choke him. He spends the next 2 years confined to his room. He is married. And he chose his brother. It's an Italian family. He chose his brother to be his power of attorney for personal care. The gentleman was hospitalized many times, and I reviewed his chart very carefully. He saw 6 excellent, what I would call excellent psychiatrists in our local healthcare system without any improvement. His symptoms became overwhelming. He was convinced that the cancer was going to choke him. His swallowing became worse and worse. Finally, he couldn't swallow at all. And a week before I met him, he was overpowered by his brother to consent to having a feeding tube inserted. Now, you might ask yourself, is this person competent? And there may be questions about that given the mental health challenges. Right? He returned home with his feeding tube, felt trapped, and he wanted to be left alone and wished that his life was over. So a meeting was arranged for me to meet with his power of attorney, his brother. His wife was present but silent, and the patient. And what the brother said to me was, what use is it for me to have power of attorney if I can't decide for my brother? And I thought, boy, I'm in for a fight here. Southern Italian brother wants all that is good for his brother. And I said to him, but that is not the law. That is not the law. You are to speak for your brother, or what your brother would decide. And he said, oh, well then. And that was the end of it. So there was a misunderstanding here about what is the role of the substitute decision maker. Interesting. So my own mother at age 82, and we had, I can't remember how far ahead we had our advanced care planning discussion, but we sat down at the kitchen table and with my dad present as well. And my mom went on to develop advanced Parkinson's disease with dementia, severe Crohn's disease, and bad osteoporosis. She lost a lot of height and weighed only 68 pounds. There were 3 of us, 3 children in the family, but she named me as her substitute decision maker and told me very clearly that if she developed any illness that would allow her to die, that she did not want to have her life prolonged. So what happened? She fell in the kitchen and fractured her hip. Should we fix the hip or not fix the hip? And a decision was made that really we couldn't care for her in comfort. We couldn't make her comfortable without stabilizing the hip fracture. So we stabilized the hip fracture. Post-operatively, she developed a severe cough and pneumonia. And we were again faced with a decision. What do we do? Do we treat the pneumonia? Do we not treat the pneumonia? So a decision was made to not treat the pneumonia because she may die and have a natural death from that cause. She didn't die. She got better. So she went on to her in this journey with her illnesses. And she developed from the Parkinson's disease chronic aspiration, so she couldn't swallow effectively. And so she kept aspirating and getting aspiration pneumonia. It was also very difficult for her to nourish herself. So the question was, should she have a feeding tube? Yes or no? We made a decision not to place a feeding tube. And when she did develop her final pneumonia, we kept her comfortable. This was not easy for any of us, but we had the security of her wishes ahead of time. And I would say that of the three of us, each of the three of us felt differently about the decisions. I want to tell you a story about someone that I have met virtually just a few weeks ago. So this person called me for assistance, guidance. The person is a 50-year-old physician with a prognosis of weeks to months. There's a malignancy involved. There are no further life-prolonging treatments available. The person has had a failed bone marrow transplant. And the patient, the person is in the final chapter of his life. His wife, who is also a physician, has had a long-standing mental health disorder, intractable depression, and is unable to work, unable to be actively involved with the children, unable to support the patient at this time. The patient has two daughters, ages 17 and 20. One is in first year virtual university, and the other is farther along, probably third year or so. Who should this person choose for his SDN? Okay, big breath. Question number 3, what about checklists? What about CPR and DNR? And what should I really talk to my SDM about? Okay, so level of care forms, we talked about that before. These do not relate to the person's specific health condition and can be very misguided. So this is not what we're talking about today, level of care forms. We talked about allowing a natural death, which is really needs to be fleshed out. It needs to be explored. If someone wishes to allow a natural death, you need to know exactly what they're talking about. Remember that resuscitation, these are sort of common things that I've encountered working with patients and families. People think that resuscitation is a buffet and they can pick things off the buffet. So typically they say, well, yeah, shock me twice. But if I don't recover, then don't shock me again. Or yeah, I want CPR if I can return to the way I was before. So remember that resuscitation is a process of multiple interventions, which are all linked one to the other. And it's not, you can't choose part of it. So if you want resuscitation, then there will be a process set in place that goes forward, and there's a loss of control until there can be a pause and a reevaluation. Okay, we've done the resuscitation, and now we're in this new scenario. Now what do we do? Successful resuscitation in a person who has an advanced life-threatening illness is rare, extremely rare, and it's extremely rare that it would restore that person to their previous baseline functioning. So, you know, there's going to be a step down effect, even if there was successful resuscitation. So it's very important to keep that in mind. It's very difficult with someone with an advanced life-threatening illness to separate a cardiac arrest from death. We can't really tell the difference. So we may have witnessed death and we're trying to resurrect a person as opposed to resuscitating them. So just be aware that the medical profession has difficulty in discerning these two things. Okay, the next thing to remember is that the right answer to the question about what you would wish is almost always, it depends. So it depends on where you are on your journey, on how much you're suffering, on what treatments might be available to you to reverse your problem. So this conversation about your wishes and your goals will change as your condition changes, and the conversation will need to continue. It is not possible for you to imagine, or for the healthcare team to tell you, all the permutations and combinations that might happen in your illness. So sharing what is important to you under various situations is vitally important. And what I would recommend, whether you're the substitute decision maker or whether you're the person, watch for triggers and opportunities. So if the person has just been admitted to hospital, this is a good time to talk about the change and what was done in the hospital. Would you want that done again? If you're watching a movie, a play, or reading a book, this is an excellent opportunity to say, you know, if that was me, this is what I think I would want. Or if you've just been through an experience with a friend or a family member, this is a very good trigger or opportunity to have ongoing conversations with your substitute decision maker. And the other thing that I want to emphasize, and I'll tell you this in the stories that are going to come up, people change their mind. People change their mind. So again, I refer you to Dr. Gawande's book, Being Mortal. Anticipated suffering may be tolerable for the joy that is experienced. Finding meaning and purpose in suffering makes it tolerable. And that's partly our job, but it's partly your job, it's partly family, it's partly social society. And what I've seen over and over again from patients, what I've learned from them is that they get to a goal, and then they move the goalpost. So they keep living until they die. So here's one example. This lady got ovarian cancer in 1977. I was pregnant with her first grandchild. She died in 1992. She just kept moving the goalposts. She died several days after this, when her granddaughter, on the day that her granddaughter is making her first communion. So imagine all the joys. Imagine. This is the lady that got me addicted to palliative care, Janet, 33, died of malignant melanoma, 3 kids. So we tried to help her with her symptoms so that she could live until she died. Here's a 13-year-old that died of asphyxiation from a tumor in her neck. Incredibly courageous, brave girl with a very, very deep spiritual belief system. Dan Blasutti, if any of you remember Hope Spring, Dan was dying of a serious sarcoma, and he was on the foundation board of Hope Spring. And I had the privilege of him teaching me quite a few things. Sandra was in her 30s. This is Fiona. She was 7 when I met Sandra, and Sandra had ovarian cancer, and she had a bowel obstruction. So her decision involved, was she going to have chemotherapy, yes or no? And because she had a bowel obstruction, she had to be artificially fed in order to consent to the chemotherapy. It's a very complicated decision. And at the time when we were making that decision, whether she should have chemotherapy or artificial feeding or not, it was all around role, maintaining her ability to mother. And I talked to her before she had the artificial feeding started about there will be a time when you will want us to stop this. There will be a time. And there was. And what she said, we had a grand rounds at which she presented at grand rounds at St. Mary's Hospital just before she died. And she said what really was wonderful about what we did was that we gave her choices. We gave her choices. And so she was actually an inpatient in hospital. She would call home to wake up her daughter for school, tell her what to wear, etc. Esther found her meaning and purpose in life in breeding dogs. So that gave her her future, her hope. Vera was a co-pastor at an evangelical church, and here she is giving testimony, what they call testimony about, God is wonderful, God is good. She's giving testimony here several days before she died. She was in a wheelchair. This is Carolyn. I don't know where she found her meaning in life. She lost her son at an industrial fall, and it was a terrible tragedy. He was 22 years old. And 2 years later, she gets ovarian cancer, and somehow she found meaning and purpose in fighting along the way. You've probably read the book Tuesdays with Maury. Tuesdays with Maury. And Maury says to the student, I still might be able to accomplish one of my purposes by being an inspiration to other people. Viktor Frankl, you've heard of Viktor Frankl. Here he is speaking at a conference. He's written Man's Search for Meaning. Every person, even up to the last moment of their existence, is free to choose their attitude to suffering. Bearing suffering with courage and dignity can be extraordinary and transcendent. Okay, so I want to tell you about Paul. When I met Paul was a principal at a school, retired. He was an old timers hockey player, and he started to fall on the ice. And he was diagnosed with ALS. And when I first got to know him, I looked after him for a number of years. When I first got to know him, he told me that when he couldn't walk around the circle in his where his house is on a circle, that he would want me to come and visit him and end his life. And what he did was he continued to transcend with each new disability. He just continued to transcend that. And the resilience was incredible. So here he is, he's making films for the ALS Society, he and his family, and to help other persons who get ALS and their families to find their way through this. This man never stopped wanting active treatment. So talk about changing your mind.
To be here more and help out more or do different.
I'm not going to show you the whole thing because it's very long, but I want to show you the end.
My name is Paul. The real me is still inside. It's just this body of mine doesn't work.
Okay, question number 4. How does the lack of conversation impact on the patient and the well-being of the SDM? So my patients have taught me that these conversations are very treasured gifts to their families. They've taught me that it allows them to have their wishes respected and their values supported. It allows their SDM to speak with confidence about what the person would want to say. The advanced care planning takes away the anxiety of the decision making that may be required. And I think that in palliative care, we say that we are committed to bereavement, but in fact, we stop seeing the patients when they die, and we actually stop seeing their families. So our advocacy about these conversations is one of the ways that we can pay more than lip service to healthy bereavement, because I think we can contribute to healthy bereavement if we do that. So what are my words of wisdom? Don't be afraid. Don't be afraid to have these conversations. But I know Shelley has said at a number of presentations, you know, Easter's coming up. You're going to get together as a family. So talk about it. But I feel in my experience that this requires time set aside and a creation of a place of safety, both in time and place. Because this requires really listening. What's the name of that book by Catherine Mannix? Listen. Requires deep, deep listening. It requires that we acknowledge what the person is saying and affirm them. And please clarify if you do not understand exactly what they're saying. Like, don't say, oh, okay, these are uncomfortable conversations, right? We want them over, but don't give up that opportunity to really deeply understand, because you don't know what situation is going to happen in the future, and you're going to help that healthcare provider team to make the right decision for the person that you care about. Remember, this is a process, not an event, so you're in there for the long haul, okay? The person's going to change. They're going to drive you crazy with the way that they change what they want. And be prepared that you'll be surprised. Okay.
Thank you, Dr. Ward. That's a lot of great wisdom to try and unpack, but I'm going to open it up. I don't know if anybody has any questions. You can either put it in the chat. I don't see anything in the chat, but wondered if people, is that you, Sean? Have you got a question? You're muted.
Sorry, I just was recalling listening to Dr. Ward some years ago on the CBC when funeral preparations and things like that came about. There was a doctor talking on this subject, interviewed, and he said, I don't see when you come into the world, it's all a lot of confusion and this what would I say, it upsets the routine of the family, etc. And he said, maybe it was tongue in cheek, when I'm going out of the world, I don't mind upsetting my kids and having them have a little bit of fluster that I had when they came into the world. It just came to mind as you know, in terms of talking about that.
Yeah, it's a circle, isn't it? It's a circle. Yeah, or you could think about paying it forward. The way that you die, the way that I die, is going to impact the way my children cope.
Mm.
the way my grandchildren like cope. So we are always learning from one another. And I think the First Nations, we've done a First Nations acknowledgement. The First Nations are very good at this, right? Learning, telling the stories, learning from each other and passing that forward. So he was doing it as a joke, but I agree with you that it is, we look after them and then they look after us. Hopefully, hopefully we've taught them well.
Anybody else have a question?
Shelley,
Shirley,
Sorry.
go ahead.
Sorry.
Cheryl, you go first.
Okay, sorry. I don't really have a question, more a comment. Dr. Ward, you were my dad's palliative care doctor in 2011. His name was Carl, and he had cancer, non-Hodgkin's lymphoma, for 14 years.
Mm.
And I want to thank you for the care that you provided, but also for inspiring me. What probably would have been a long, drawn out dying process in hospital, for my dad changed very quickly. We kept him at home. We cared for him right there in the living room. You brought in all the supports we needed. And it was the most beautiful experience I have ever encountered. And it really was life-changing for me as a caregiver to my dad. And I just want to thank you for that inspiration. I since left my career in social services and have gone back to school and studied palliative care and spiritual care, and have recently finished the end-of-life doula program. And
excellent.
my mom passed away in October. And, you talked about how this impacts generations. My daughters were very young when my dad died, but they did see him in that dying process. They were able to say goodbye, and it made things so much easier with my mom. She was in hospital, but it was a beautiful time to say goodbye, and we had those opportunities to have those hard conversations about mom's care, and she didn't want to prolong her life either. And it was a natural dying process, and it was beautiful. And, my mom said to me, she said, "This is exactly how I wanted it. I'm not alone." And that was, the morning that she passed away. So it was just such a beautiful experience. So I just want to thank you so much.
Well, I'm very grateful for you sharing that. And I hope that you find your career as wonderful as I have found mine. Yeah, it's a great vocation.
Can I just add on to Cheryl's comments? You have just proven what Dr. Ward said to us before about how dealing with this ahead of time makes your grief so much kinder and gentler than what it might have been had you not been prepared by having conversations.
It absolutely does. And I will say, with my mom being in hospital, it started with a heart attack, and she went through this phase of, within the first 2 days, we were talking hospice and palliative care. And then she kind of had a bounce back. And then it was like filling out paperwork to put her in long-term care. And then all of a sudden, we think she had another episode of heart failure while she was in hospital. Her condition just changed drastically. But, with my brother and I there as her substitute decision makers, as having her there. And I kept saying to the doctor, at that point, my mom still had her, like cognitively, she was able to make her decisions, and he kept talking to us. And I kept saying to the doctor, my mom can speak for herself, and I think that was really honoring to my mom in those moments, and again, like if I hadn't had these experiences, if I hadn't learned these things over time and just knowing the right questions to ask, because it was still confusing, and I consider myself fairly well versed in this, but it was still confusing. And I think what I saw from one of the doctors was his resistance to allowing my mom to die. It was almost like he felt it was necessary to prolong her life, and Dr. Ward, you talked a bit about that, right? So, it was interesting to see the impact that it had. So yeah, thank you.
That comes from our training, is to fight disease instead of working with the patient, right? So it's they call it dualism, where you separate. And in the Middle Ages, they didn't do that. They didn't have very many medical treatments, so they treated the person. But now we're so busy treating the disease, the person kind of disappears. And patients actually are loath to tell their physicians that they want to withdraw from dialysis, or they want to withdraw from chemotherapy or whatever, because they don't want to disappoint their doctors. Like, how backwards is that? Yeah. Thank you,
Dr.
Cheryl.
Ward, I was going to ask you a question about the young people, and let me just frame it in terms of where I'm coming from. I just recently had an opportunity to do one of our presentations with a group of students at Renison College, and they were all in their early 20s. And one of the young women in the audience and the classroom was telling us about her experience of losing her mother when she was just 13. Can you talk to us a little bit about the kinds of conversations we should be having with children who are experiencing the death of a grandparent in many cases, or unfortunately for some of them, a parent? How do we talk to them? How do we have these conversations with young people?
Well, I'm going to be speaking to a group of high school students tomorrow that are interested in healthcare careers. I think it's an art, it's a specialty to approach children because they are in different developmental stages. I think as much as possible not to shut them out, but also not to force them. So Cheryl, with your children and your dad, it's important to involve them in whatever capacity they wish to be involved without frightening them. It's very difficult. I mean, I can remember one lady who was dying. I remember the room she was in the hospital, and her daughter was supporting her. So she was sitting on the bed facing me, and the daughter was sitting on the bed with her back behind her mom, supporting her mom in the sitting position. And the mom was saying how ready she was to die. And I walked her on the other side of the bed, and the daughter was just, these tears were streaming down her face. So this, this tension between death readiness and acceptance and the feeling of abandonment that the child was feeling. She would have been maybe 13, something like that. So I think we're wrong to shelter children, but we need to approach them at the level that they're ready for. And, we did have a very robust pediatric program at Hospice of Waterloo Region. I'm not sure where it's at the moment, but it was tremendously valuable. We had also a camp that they could go to once a year in the summertime. So yeah, we can do more work in that area, Patty, and you've got the background in education.
Yeah.
So we need to do more.
But it's not easy, is it?
No. And you also have to have the parents' permission. We're training paramedics now in providing the appropriate response rather than just putting the person in the ambulance and hauling them to the ER when they're dying, to be able to respond. And one of the scenarios is a child and the paramedic talking with the child in the home. And, it's very important. You must have the parents' permission because the culture, you don't know really whether what you're going to say is going to be acceptable to that culture. And you're just there in the moment, right? So part of our role, I think, is coaching parents to like working with the parents because they're going to be there after we leave.
Yeah.
We need to do more work on this.
Yeah.
And just as an aside, I think that our two counselors at hospice are starting up a support group this spring, a grief support group that's geared towards young adults, young children. So hopefully that will start to move, because as you said, Donna, there used to be resources, and those are not available anymore. So we need to get back to looking at how we can support.
Yeah,
young
one
people.
of the very best partners are play therapists,
Yes.
child play therapists, and having gone through an experience personally with a child sick at McMaster, the play therapist was one of the most highly valued members of the team for us. Yeah, they just know how to do it.
One of the questions we get a lot, Dr. Ward, and you referred to it earlier about, okay, what do we talk about? And people wanting a checklist of treatments, okay, if this happens, I want this one, or I don't want that one, that sort of thing, which we try and steer people away from to get back to what's important to you. Dr. Mannix uses the term priorities. What are the priorities in your life, which also change over time? You talked a little bit about meaning. What brings meaning to your life? So if someone asked you, what should I talk about? I'm getting together with my mom on Friday. I really think it's important that we have this conversation, but I don't know what to talk about. I don't know what to ask her. What would you say to that person?
Well, I think I would start with, where are you at with things? Like, I try to be as vague as possible, because sometimes the person wants to take you in a totally surprising direction. So it's kind of where you're at. If the person is not ill, then the conversation is much more vague. But if the person has an illness, then understanding, okay, where are you at with that illness? How much are you suffering? Are you suffering? Maybe you're not, even though you look like you are, And then what things are important? Are there things coming up that you're hoping to be there for? And what things can you live without? What things can you not live without? And appreciating the fact that they can get there. It's like asking a blind man, we always think that a certain thing is going to be intolerable, but then when we get there, we may not. And again, that search for meaning and purpose, and being comfortable with being, because we're all doers, right? We all have a vocation of some kind. So your team, for instance, is finding meaning and purpose in what they're doing, right? And this is their second or third or fourth career. So finding meaning and purpose. But what if you're not able to do any of those things? When would you be ready? And some people, like Paul, were never ready. Some people go out like this, shall we? They never get ready. And other people get to a place of peace. And you can't force that, but it is quite beautiful when someone reaches that place of peace.
Thank you. That's a good answer.
Mm-hmm.
Lynn?
Dr. Ward, you touched on not appointing a committee to make decisions on your behalf. And I love when you said that anybody more than two people becomes dysfunctional within a family, which is so true. I'm sure in your career, you've had many, let's call them horror stories of families that could not get on the same page. And how difficult must that have been for their loved one, not getting good decisions made on their behalf?
Mm-hmm.
Do you have any words of wisdom for people how do, so you have 4 children and you only want to appoint one of them. Are the other 3 offended, or are they saying, yay, it's not me?
Yeah, exactly. And some of them are saying, yeah, it's not me. And some of them are probably offended, right? And you have to listen to that. But I can remember the most challenging meetings. So if the healthcare team is working with a complex family, say 8 children, okay, and there's one substitute decision maker, the decisions are made with the substitute decision maker, but that's not where the responsibility of the healthcare provider stops. The healthcare provider needs to hold a family meeting. And in very anticipated difficult situations, I wouldn't do that by myself. I'd have the social worker there, I'd have the nurse there, I'd have, you know, whoever I thought could be helpful. Sometimes you have the ethicist there. And you have the family meeting and you try to establish ground rules and safety and allow people to speak their mind. But in the end, it's the wishes of the person expressed through the substitute decision maker. I mean, everybody can't participate in the decision making, but you want everyone to be healed. You don't want the family, no patient wants the family not to be speaking to each other after the funeral. So that healing is critical. And those meetings, I mean, you have to go into them with courage. You come out, you're sweating bullets, you know. And I mean, literally, you pray that you have the right words to support the substitute decision maker and those family members who don't agree, to support them all, because they all need a healthy bereavement. Yeah, so it's those family meetings need to happen in concert with the decisions. Yeah. Yeah. So that's where the committee comes in.
Yeah. Okay, I see that we're almost done here. Anybody else have a question? Otherwise, we can bring it to a close. I do have a little poll that I'm going to launch for anybody who can take a minute to fill it out. ACP team, you don't need to fill it out, just to get some feedback. And I'm sure everyone here would agree with me, Dr. Ward, and wanted to thank you so much for taking the time, not only to put that PowerPoint together and walk us through it, but to share all those stories. And those stories are the things that are going to drive forward. You know, I know in our next presentation, how we talk about advanced care planning and meaning at the end of life. So I want to thank you for this time. And have you got a presentation every day this week? Sounds like you're doing one tomorrow.
No, I think that's the end for a little while. So you can call me if you need me.
Oh, we know where to find you. Thank you. And on behalf of everybody here, thank you so much for taking the time. And as I said, Dr. Mannix is going to be our next guest on the 12th of April, and you can go to our Hospice Waterloo website to sign up for that on the events page under community. And yes, I realize that getting together at Easter is not the place for the tender conversation, but we do not talk about death in this society, and we need to open that up. And just as you said, Dr. Ward, you know, use something that you've seen, use this presentation as a starting point, just to get the conversation open. So thanks very much, everyone. Dr. Ward, thank you so much.
Thank you for your participation, everyone, and for kindly listening to my stories.
Anytime. Thank you.
Okay.